Today we'll be discussing about bronchial asthma. So bronchial asthma, defining bronchial asthma, it is disease characterized by increased responsiveness of the airways to various stimuli. Okay, it manifests by widespread narrowing of the airway, causing paroxysmal dyspnea, wheezing, or cough. Okay, now let us talk about pathophysiology. Okay, so initially what happens, there are four etiological agents. They are atopic, non-atopic, exercise induced, and aspirins. Okay, so when there is etiological agent over here, okay, when there is etiology that causes individuals, okay, individuals what, individuals with genetically susceptible genes. The susceptible genes is here is adam 33 genes. Okay, adam 33. Okay, so adam 33 in the genes that regulates this upper lower airway. Okay, so when there is mutation in these things, what happens, the risk of asthma increases. Okay, so individual with genetically susceptible genes, what happens, there will be sensitization. Okay, when there will be sensitization of the airway with inhale allergens, okay, there must be etiology, that is inhale allergens. Okay, so when there will be inhale allergens will be there, then what happens, there will be activations, stimulation of the T helper cells. Okay, when the T helper cell get activated, it releases three things. Okay, interleukin 4, interleukin 5, and the interleukin 13. Okay, these three things will be released. So interleukin 4 causes production of IgE antibodies. Okay, it causes production of IgE antibodies, whereas interleukin 5 causes activations of locally recruited eosinophils. Okay, it causes recruited eosinophils activations. Okay, so it activates locally recruited eosinophils. Okay, so interleukin 13 causes what, interleukin 13 causes mucus production. Okay, it stimulates mucus productions. So these three things causes what, these three things causes final things over here. Now there will be Ig course with submucosal mast cells. Okay, so these three things causes IgE that need to be coated with the mast cells. Okay, coated with mast cells. Okay, so when there is repeated exposures, then what happens, there will be degranulation of the mast cells, causing release of granules contents and release of cytokines again. Okay, so what happens, that causes release of granules contents and release of cytokines again. So when there is release of cytokines again, and when there is release of granules contents there, then what happens, there will be two phase reactions, early phase reactions and the late phase reactions. Okay, so same thing, let us revise it again. So when the etiology is there, okay, that etiology causes individual with genetically susceptible genes sensitization of the airway. Okay, when there will be sensitization of the airway, there will be activation of the T helper cells. When there is activation of T helper cell, it causes release of interleukin 4, 5, and the 13s. Okay, that interleukin 4 will causes production of Ig antibodies, and interleukin 5 will causes activation of locally recruited mast eosinophils, and interleukin 13 will causes mucus production, that now they coated with mast cells. So what happens, the mast cells degranulation take place if there is repeated exposures. As a result, there is two phase reaction, that is early phase reactions and the late phase reactions. Okay, in early phase reactions, what happens, there is bronchoconstrictions. Okay, next thing is mucus productions and vasodilatations. Okay, so these three things take place over here. Okay, in airway there is bronchoconstrictions, there is mucus production, but in the blood vessel there is vasodilatations. In late phase, what happens, there is inflammations. Okay, inflammation with recruitment of leukocytes, notably eosinophils, and more T cells. Okay, So now these three things, these two things, okay, these three things over here and these things over here causes what? Causes the asthma with clinical presentation. Okay, so same thing over here. So let us define bronchial asthma lastly. Okay, so bronchial asthma is disease characterized by increased responsiveness of the airways to various stimuli. Okay, so that causative agent, that pathophysiology causes responsiveness of the airways to various stimuli. So it manifests by widespread narrowing of the airways, causing paroxysmal dyspnea, wheezing or cough. Okay, so pathophysiology same things. Okay, there will be edema, okay, inflammation of the mucous membranes lining the airways, excessive secretion of the mucus, inflammatory cells and cellular debris, spasm of the smooth muscle cells of bronchi, obstruction will be there, that is diffuse but not common. So okay, now the etiological agent, they are atopic, non-atopic, exercise induced or aspirin induced. Okay, in atopic there are triggers like environmental allergens such as dust, pollen, animal danders and food. Non-atopic we have no evidence of allergy sensitization, okay, but there is positive family history, okay, of asthma, because that is non-atopic causes. Okay, and drug induced also there, that is aspirin. Sometimes there might be occupational asthma, that is asthma induced by fumes, chemical dust, wood, cotton, platinum. Okay, so these are the things over here. Okay, so moving further, there is early phase reactions and the late phase reactions. Early phase reactions that start within 10 minutes of the exposure to allergens. It is characterized by release of histamines, leukotrienes, prostaglandins, platelet activating factor, and bradykinin from the mast cells, following the interaction of allergen with specific mast cell bound Ig. Okay, that causes same things: bronchoconstriction, mucosal edema, mucous secretions which manifest as ear obstructions. This phase is inhibited by beta 2 agonist drug. In late phase, what happens? Occurs in about 2/3 of patients. It develops 3 to 4 hours later, peaks at 8 to 12 hours. The release of mast cell mediator is not prevented by pre-medication with beta 2 agonists. Okay, we have to give steroids. Pathology, same things over here. Okay, so triggering factor of the asthma are viral infections, role of exercise, weather changes, emotional factor, role of food, endocrine factor, okay, and clinical features. The patient present with these three things. Okay, they are dyspnea, wheezing or cough. Cough is non-productive. Okay, normally dry cough. Okay, they will present with dry cough. Okay, so symptoms vary from simple recurrent cough to severe wheezing. Symptoms occur with change in season, aggravated by exercise or more at night. Okay, so symptom is more at night. In the early phase of the episode, the cough is non-productive. Okay, the patient becomes dyspneic with prolonged expiration and wheezing. Accessory muscles of respiration are excessively used. The child sweats profusely, may develop cyanosis and become apprehensive and restlessness and appear fatigue. In a severe episode, the child may show ear hunger. The chest is hyperresonant because of the excessive ear trapping. As the obstruction becomes severe, the ear flow decreases markedly. As a result, the breath sound becomes feeble. Okay, wheezing, which was audible, may disappear. Okay, absence of wheezing in the presence of cyanosis. Okay, in late phases, what happens? There is absence of wheezing in the presence of cyanosis and respiratory distress should not be considered as an evidence of clinical improvement. As a result, breath sounds become feeble. Wheezing, which was earlier audible, may disappear. This is called as ominous signs. Okay, severe hypoxemia might be there, asthma result in cyanosis and cardiac arrhythmia. Okay, pulsus paradoxicus indicates severe illness. Okay, so mucus plugs occluding the bronchial tree may cause collapse of small segment of the lung. Okay, persistence of the hyperinflation of the chest even after subsistence of asthmatic attack signifies the apparent relief from bronchospasm will be short-lived. Okay, in chronic intermittent cases, the chest becomes barrel shape. Rubbing of the finger, however, is unusual. Okay, so this is the things over here. Okay, so diagnosis: the prolonged whistling sound heard at the mouth during expiration is called as wheeze. Recurrent attack of wheeze indicate bronchial asthma. Okay, although intermittent attack of coughing may be due to recurrent viral infections, diagnosis of bronchial asthma should be considered. Cough, which is associated with the asthma, generally worsen after exercise. Sputum is generally clear and mucoid, but expectoration of the yellow sputums attributed to large number of eosinophils does not exclude diagnosis of asthma. Okay, chronic spasmodic cough may suggest occult asthma. Okay, investigations we can do spirometry. Spirometry we can do PF. You can check PFR. Okay, FEB1, PVC, and FEB 2575. Okay, and we can do absolute eosinophil count. We can do chest X-ray. In chest X-ray, there will be bilateral and symmetric air trapping in the case of asthma. Okay, patches of atelectasis may be varying size due to mucus plugs. Plugs are not usual. Okay, allergy test we can do, that is rust we can do over here. Okay, management. So three things we have to do, look for during the management. Okay, so identification and elimination of exacerbating factor, pharmacological therapy, and education of patients and parents about the nature of disease and step required to avoid acute exacerbations. So identification and elimination of exacerbating factor means we have to identify the risk factors, that is atopic, non-atopic, drug induced or occupational asthma. Okay, so we have to remove these four things, that is identification and elimination of exacerbating factor. We can do carpet, stuff, furniture, loose clothing, wall hanging, calendars, and look attract lot of lot of dust. Okay, should be cleaned periodically. Okay, so we have to keep clean. Okay, and we have to educate the child if they are adolescents. Okay, so adolescent patients will be advised to refrain from smoking. Okay, have to give them knowledge about smoking's allergens and everything over here. Okay, bronchodilator. So bronchodilator, these groups provides immediate symptomatic relief. They may be short-acting and long-acting. Though commonly used short-acting bronchodilators are adrenaline or butylene and salbutamol. All of these have quick onset of actions. Okay, adrenaline stimulates both alpha and beta receptors, thus having cardiac side effect. So we normally not use adrenaline. Butylene and salbutamol are specific beta 2 agonists and have a few cardiac side effects. Adrenaline is given subcutaneously. Okay. The other two agents can be administered by oral N or inhalations or parenteral routes. Okay, inhalation route is preferred because of quick onset of actions and fewer side effects. Long-acting beta agonists, that is salmetrols and formoterol. Both these drugs are beta agonists and have a long duration of action, that is 12 to 24 hours. The onset of action is delayed by 1 hour. Okay, the safety and efficacy has been demonstrated in children above 4 years of age. Okay, corticosteroid. We can also give corticosteroid. Okay, we can normally give these things in late phase reactions. Okay, the bronchodilators can be given in early phase reactions. Okay, corticosteroid causes drugs are dexamethasone, budesonide, and fluticasone. Okay, this corticosteroid might cause growth retardation for 1 year. After 1 year, there will be no change. Okay, the velocity recovers and children ultimately attains predicted adult height. Okay. Theophylline. Theophylline has concentration-dependent bronchodilator effect. Bronchodilator effect is exerted by inhibition of phosphodiesterase. Okay. In addition, the theophylline has anti-inflammatory and immunomodulatory effect at therapeutic serum concentration that appears to be distinct from its bronchodilator properties. Okay. So now let us treat the bronchial asthma. Okay. In stepwise. Okay. We can grade bronchial asthma with intermittent, mild persistence, mild persistence, and severe persistence in the basis of PFR, FEV1, and symptoms. Okay, so we'll be treating that things. Step 1, we can give long-term prevention inhaled short-acting beta 2 agonist as required for symptomatic relief. If needed more than 3 times a week, move to step 2. Okay, that is intermittent. In intermittent, we can give short-acting beta 2 agonist. That is the things over here. Step 2, that is mild persistence. We can give same things, inhale short-acting beta 2 agonist as required plus inhale budesonides, fluticasone or beclomethasone. Okay, or cromolyn sodium or sustained release theophylline or liquid modifiers. Okay, we can give short acting beta 2 agonists. We can add corticosteroids. Okay, that is the things over here. In step 3, we can do same thing, beta 2 agonist is required, inhale budesonides, fluticasone or beclomethasone. If needed, salmeterol. Okay, 50 mg q 24 hour. Okay, that we can give over here, QID over here. Okay, or sustained release of theophylline. Okay, we can do over here. We have step 4, severe persistent, that is inhale short acting agonist is required plus inhale budesonides, fluticasone or beclomethasone. Okay, salmeterol or formoterol or sustained release theophylline plus oral low dose prednisolone in alternate days. Okay, so this is the things over here. So step 1, we can give long term prevention inhale short acting beta 2 agonist. Step 2, mild persistence, we can give short acting beta 2 agonist plus inhale budesonide, fluticasone or beclomethasone. Step 3, we can give beta 2 agonist, inhale budesonide, fluticasone or beclomethasone, that is corticosteroids. If needed, we can give salmeterol. Same things over here, but we can need theophylline over here. Okay, in this way we have completed pediatrics, that is asthma. Okay, bronchial asthma. Okay,